Hello, good morning, everyone. Welcome back. This is Bangladeshi Emergency Medicine Community. I'm Dr. Farooq, one of the consultants in emergency medicine in UK. Today, we have Dr. Uday Jatiga, who is my dear colleague and one of the senior emergency medicine trainee in East of England. Welcome, Dr. Uday. We are really excited to have you this morning. And we would love to hear a brief background where you're coming from, what made you come to emergency medicine. Then we'll dig it deep into our topic today. Dr. Uday, please.
Thank you, Dr. Farooq. My name is Uday. I'm one of the highest specialty trainees in East of England region, and that is how I know Dr. Abdullah. So I've been in the training for the last 8 years now. The first 2 years I worked as a non-trainee job in A&E, and then I took up training. And as you guys know, it's a 6-year training process. So I've rotated in different hospitals as part of my training. I was in multiple places like Peterborough, Cambridge, Luton, and Watford. Essentially, East of England is a very big region in the UK, and Dr. Farooq was also he trained in the East of England region and he's a very dear friend. Thank you very much for giving me this opportunity to share one of my experiences and as well simultaneously to use it as a learning opportunity for all of us.
Thank you so much, Uday. Very, very nice introduction. And again, because today is a bit of for most of the audience, I would say, even for us, it's a very rare procedure as an emergency physician. And I would say we'll be lucky to be involved in one of these in our entire life. Okay. So, however, the reason I asked Uday to join us is he is one of the rare colleagues who actually was involved in it is resuscitative thoracotomy in ED. So let's talk about it, Dr. Uday. So Uday, can you tell us exactly before that event? So are you working the shop floor? So you had a pre-alert. So
Yeah,
give
let
brief
okay.
idea before what happened before you get ready.
Oh, certainly. So I just came into my night shift, and then I was the team leader for the shop floor that night. And we received a pre-alert, and as you know, the hospital that I work in, there is a relatively higher incidence of crime around there. So there was a stab injury, and then there is a specialized pre-hospital team who deal with conflict situations. So they are specially trained in case if there is any use of weapons or ammunition around that region. So these paramedics are specially trained to handle those situations. We received a pre-alert, and I was about to take the handover of the department from the consultant who is leaving the shop floor. So we knew that this is a middle-aged male who was stabbed in the chest, and and that is all we could get because the paramedics were really what do you call quite anxious around the situation. You can understand the commotion. So we don't have a full set of vitals, is what they said, but then we are very, very concerned about this gentleman, and then we were worried about a lot of blood loss. So we understood, fine, there is a stabbing to the chest. The worst possibility that could happen is to actually open up the chest to save this gentleman. But that is only a part of the jigsaw puzzle. But the main thing is the preparation that goes into the mind. Um, Someone else's screen has come up. Okay, so the main thing is the preparation that goes on in the head, wherein, as you have rightly pointed out, this is not a procedure that you do day in and day out.
Mhm.
And since it is one of those high acuity, low occurrence procedures, there may not be actually anybody in the hospital who might have done this procedure before. So in the mind, but obviously you would have a bit of theoretical knowledge about how to do this procedure and a bit of visualization of the anatomy. So me and one of my other colleagues, so we went through the procedure in our head since we had a lead time.
So I before you go into deeper, so just to summarize for the audience, again who are joining later. So this is Dr. Uday, who is describing us a real life scenario on resuscitative thoracotomy. The story is there was a middle-aged man who pre-alerted by the ambulance crew coming to the emergency department where he was working, having a stab injury in his chest. So that's the before. So what? So in terms of stab injury in the chest, what are the situations, Dr. Uday? People might ask, why would you even consider thoracotomy, and what was the rationale?
Yeah. So there is no way of assessing how deep the injury would be based on just your naked observation. So if you look from externally to internally, the things that could happen is perhaps the knife was a bit blunt and then it could stop at the chest wall. That is the most insignificant thing. And then if it goes a bit deeper, it can cut into the internal mammary artery and then they could bleed profusely from the internal mammary. If it goes even deeper, then it could cause a pneumothorax or a hemothorax.
Right.
However, if it goes even a bit deeper, then it can go into the heart, and then that is when we'll go into the resuscitative third.
Right, right. And by the time you get a pre-alert, was there any indication that patient could be unstable or having a stab in the heart from the pre-alert?
Well, that's a good point. Because we weren't expecting, we weren't anticipating this because this happens so seldom. We were actually prepared for the hemopneumothorax, and then we planned to put a chest drain in. However, we in A&E, as they say, we have to always rule out the worst thing. You have to think about the worst possible thing. So, which is why we thought the worst possible thing that could happen in this case is a resuscitative third.
Right. But the moment I'm expecting also the patient still has a pulse,
Yeah.
was signs of life, is not a cardiac arrest.
No, it wasn't.
It wasn't.
It
But
was.
back of your mind, you have thinking about. So since after receiving call until the ambulance arrived, there's a time to prepare. How much time you had? Five,
So
10?
we had about 10 minutes lead time.
Yeah. So can you tell us in 10 minutes what you did to prepare?
Okay. So in 10 minutes, I think the beauty of A&E is when you are prepared, you can be a lot more structured amidst chaos. So as we have mentally visualized, for the standard procedures like putting in a chest drain, we have a chest drain kit readily available. So likewise, we gone through the procedure in our head. So in the beginning, you would need some cleaning solution. You would need some scalpels to cut open the chest, and then we have these specialized things to retract the ribs, the inferior half of the thorax and the superior half of the thorax to retract it to be able to actually visualize the heart and the lungs. So we were and then as we ran through the procedure, then the other things that you would need is um, the most, they may sound quite silly, but then you have to be prepared for these things. You need extra pair of sterile gloves. You need to be donned and ready. And because there is no time after the patient arrives or if they have arrested to go through all of these things.
Right.
So
So,
that 10,
yeah. So did you
that 10,
actually prepare the thoracotomy kit on the side at the
yes,
Oh, wow. And who are your team members? You call the trauma team, isn't it? So
yes.
who are the team members there that supported you in terms of thoracotomy?
Yeah, so to be honest, I was very fortunate, I would say. The timing was also very fortunate because I was coming in to take over the department on the night shift, and then we had the late shift doctors as well.
Hmm.
So me and my colleague, we were two registrars, and from the evening team, there were two registrars.
Right,
And from the NS, obviously, when we put the trauma call out, then we had the anesthetic support, general surgical support, and the orthopedic support.
right. And anyone was trained in thoracotomy who was supporting? Or
So it was just me and my other colleague who was helping,
it was our ED colleague?
and another ED colleague.
Okay, okay,
So
wow.
he was pre-hospitally trained,
Yeah,
and we worked together actually.
okay,
And
Have you?
I think this is what happens when all the stars align and then you come
Yeah.
under the same roof.
Yeah, that's a very good. Thanks again. I'm just gonna. There are a couple of people coming in, so we are all talking about resuscitative thoracotomy preparation stage. So a middle-aged man stabbing you in the chest. Dr. Uda was on the night shift, just coming in the night shifts, and he has other colleagues who was gonna leave. But anyway, he was fortunate enough to have a colleague who was pre-hospitally trained, and both of them in mentally. So as we said, the worst case scenario is the stab injury in the heart, and and then we need to have to open and decompress the chest and the heart. So I think that's preparation. So on the pre, it wasn't obvious that patient needed thoracotomy, but I think it's a good thought that anyone coming with chest stabbing the chest, just to be prepared in case we need a thoracotomy. All right, so we got the pre-alert, we got the team ready, your colleagues ready, ITU, surgical team, orthopedics. Um, and then, okay, and in the preparation wise, you had the, I know you're talking about the chest drain kits ready, the thoracotomy tray ready. Okay. Is there anything else you did in
Yeah,
preparation?
certainly. Um, because in case of injuries to the chest, there will be a plenty of blood loss that could happen.
Right.
And sometimes it could be over 2 liters or 3 liters,
Yeah.
and there's no way to anticipate that.
Right.
So we have the what's called as a rapid infuser.
আমি মনে হয় গাধার মতো দুইবার টাকা কাটছি
Excuse me. Can someone yeah, mute, please. If you're not talking, please mute. Fine. Thank you. All right, Dr. Uday, sorry about the interruption.
So we have had the rapid infuser. So the rapid infuser takes about 4 or 5 minutes for it to be primed and kept ready. So which is another thing that I've asked to keep the rapid infuser primed and ready. So the rapid infuser with us is quite beautiful. So if you have an orange color needle, then it can infuse a unit 1 liter of blood within 2.5 minutes.
Wow, wow. And you activated the major hemorrhage protocol at the same time, and the rapid infuser. That's amazing thing. Yeah, yeah.
So we were prepared with that as well.
Wow.
So in this stage, what I feel is persuading your nursing staff is can be a difficulty
Yeah,
because not everybody would be on the same page or
mm,
be thinking as catastrophically as you do. But
right.
as a team leader,
Yeah,
sometimes you have to be authoritative to be able to push things and then get them the right way you do. Because people can do become complacent and then they can be like, okay, let's see what happens after the patient arrives.
right.
But then that
And
we shouldn't be living to that stage.
exactly. In terms of allocation, how did you allocate and how did you manage the crowd? There will be a crowd anyway.
Oh yeah, so the crowd was immense, and then it was a very exciting thing for everybody. So crowd management is another skill, certainly. Um, so I can say that this procedure was solely done by A&E team
Mm,
um, because there wasn't even enough time for the other people to pitch in.
right.
Um, so fortunately, me and my colleague, we both of us who were assisting, all the staff do know us, and we did have a sort of an authoritative tone, I would say,
Mm,
uh, because nobody would be shouting there, but then most of them would be whispering to each other.
right.
Uh, would be whispering to, and then these cumulative noises increase the overall decibels, the noise decibels within the room,
Right.
which can add to the chaos. So we did this in quite a military style, wherein the commanding officer um, commands the troops to be
Right.
quiet or do a certain drill. So essentially, that was how I think we managed the crowd control.
Thank you. And in terms of allocation, what the allocation was spread out like?
So allocations wise, so we needed so the standard principles are A to E.
Yeah.
Essentially, in this case, it is C A B C.
Hmm.
So me and my colleague, we were at the chest. We
Right.
had two registrars at the airway end,
Hmm.
and then we had a senior nurse in charge who can handle the rapid infuser.
Right.
And then we had the best of our doctors who are very good with IV cannulas at the cannula.
Right.
And then so there is every possibility that the patient could be totally drained of circulating volume. So we had the IO drains, IO kits,
Ready as well.
and then ready,
Hmm.
opened, screwed in, and ready. So even those 3-4 seconds do matter.
Yes. And in terms of primary survey, is it you guys or?
So primary survey was A&E, but then let me explain the story as it unfolded in front of us.
Okay, okay.
So then, so the patient was pre-alerted, and then we had a mentally we ran through the situation, and the patient was still alive during transit.
Right. So let me stop you there. So let's say preparation is ready. The patient just arrived. Okay.
Yeah.
Can you walk us through from their right handover and the next steps?
Oh, certainly.
Yeah.
So as they were coming in through the main entrance of Resus, the paramedics was on the chest, and then they just started chest compressions.
Oh, wow. So he just arrested onto entering into the emergency department. Oh, okay.
Yes. Yeah.
Right.
So as the ambulance was coming in, as it was on the ramp, that was when he had a cardiac arrest.
Hmm.
And then the paramedics started chest compressions. And then as he was coming in, being brought in, the paramedics, they did announce that the patient has just had a witnessed cardiac arrest.
Right.
So
Just,
theoretically
just,
speaking,
just to let the audience know that it's a witness cardiac arrest, stab injury, and it's an indication within 10 to 15 minutes. It's an indication of resuscitative thoracotomy and decompress the heart. So I think it's a very right timing, and your team is right there. Okay, carry on.
exactly. So as you have rightly pointed out the definition of the indication, so it met the indications, and then we were certain that this is under 10 minutes. So we were prepared for resuscitative thoracotomy as the patient walked in.
Right. Okay. So tell us what happened
Yeah.
handover and what
So
you.
I think the first biggest challenge is to make the decision.
Hmm.
The decision make because whether you do a thoracotomy or do not do a thoracotomy, there would be criticism
Yes.
on either side.
Yes.
And that is something we have to accept. And then at that point of time, when you make a decision, then that is it. You act with the decision.
Yeah. Just quick question. Was there and what time was night was it? What time was it? Was there any ED consultant around?
So, there was, and then actually no, our consultant left, and then it would take another 15 minutes for them to
Right.
arrive
I
back.
what time was it at night time?
So
What
it
time?
was 22:40, I think,
22:40. So 10:40. Okay, fine. Okay.
10:40 p.m.
Okay, then yeah, carry on. So
So it was around 10:40 p.m. Not 10:40, sorry, 11:40.
11:40, that's fine.
11:40.
Yeah. So
Because everything was done before midnight.
so paramedics doing CPR, patient arrived in Resus Bay.
Yeah.
Right.
So we took the patient into Resus 1, and as the patient was being wheeled in, then we poured the betadine solution onto the chest.
The decision was made before they handed over, or when did you make a decision of this, or after the handover?
So as the patient was being wheeled in,
I see. I see.
as the patient, so we one look and
Mm-hmm.
decided, yeah,
Gonna
we
go.
let's go ahead.
All right. So carry on. So you just said patient was from the ambulance tray. Is still in the ambulance tray, or you transfer the patient first?
Right. So the patient was on the ambulance trolley, and then they were very quick. So these paramedics are exceptionally trained. I mean, the physical fitness is also very good,
Okay.
and so they were able to transfer
Yeah.
within 3 seconds onto
Right.
our trolley.
Okay.
So the patient was transferred,
Mhm.
and by then we have poured the betadine solution on him. And whilst in transit, whilst he was in the ambulance, he has already had thoracostomies done.
Oh, bilateral thoracostomy, finger
So he has
thoracostomy.
had bilateral thoracostomies done.
Right. This is very important for the audience. I think the paramedics are very trained here. They have like already did the bilateral finger thoracostomy, which is, I mean, if it was a query tension pneumothorax or massive hemo, that would have been relieved by now.
Yes, indeed.
All right.
So we were expecting a hemothorax.
Mhm.
That obviously looking at the multiple chest injuries to the chest. Um, so bilateral finger, but then there was no blood flowing out
I
from
see.
the thoracostomy.
Right.
So now all we had to do was to make the incision um, and then rip open the chest. So we did a clamshell thoracotomy.
Right.
So we started our incisions from the xephisternum, and then we followed along the intercostal space, and then we reached the bilateral thoracostomies.
So two of you registered on two sides,
Yes,
and you start in the midline and go across
yes,
the thoracostomy side, isn't it?
yeah.
So it's like a clamshell open chest. Okay, fine. Yeah. Let's see.
So there's a question they asked, was there any prior consent taken?
Well, yeah, can you explain this? That was a question from one of our colleagues, Dr. Parvez.
Certainly. So these are circumstances wherein you intervene in the best interest of the patient, and then you are protected by the common law. It's called
Yes.
the English common law. So
In
as long as you're doing in the best interest of the patient, you're protected. And then the patient is in cardiac arrest, and obviously they wouldn't have any capacity to consent. And at the same time, there is no we have no access to resuscitation status of the patient or their lasting power of attorney either.
right. And
So
also,
in such dire circumstances, the law safeguards us to intervene in the best interest of the patient.
and this is one of the key point, I think, in countries like Bangladesh or other countries, they probably don't have that law actively. Even the patient's relatives and other people sometimes get very angry and upset, and may have a his incidents of violence as well. So these are the things I would say very tricky in and other countries like Bangladesh, but in UK we are well protected. We don't need consent. In that time, even we didn't have a time for consent. We just act on our best interest.
Yeah.
Um, any other questions? So no, that's fine. Okay. So consent, as I say, it's an implied consent. We just carry on. So as I say, can you just carry on. So you guys start in the incision. So clamshell is like they open the whole chest. So tell us briefly what is the procedure you done?
Yeah, so we started our incisions and then we met at the thoracostomy site. However, it was only a skin and subcutaneous tissue deep incision.
Right.
And so
So
you
it's like
have to cut.
equipment wise, you use like size 10 or 12.
So we had a size 11 blade,
Size 11, yeah.
and then we got the blades, and then made I mean, the scalpels. We made the incisions, and after the incision, then now the muzzle is exposed.
Yeah.
So we have to cut through the muzzle.
Right.
So to be able to cut through the muzzle, it's not a plastic surgery. It's not a very pretty surgery. So we had to use the tough cut scissors.
Right. The big, yes, yes.
So the tough cut scissors has a blunt front end, so
Hmm.
it doesn't pierce.
Yes.
However, no matter how thick the tissue is, the tough cuts can cut through it.
Right. Okay.
So we cut through the intercostal muscles.
Yeah.
We cut through the intercostal muscles. And as I was cutting through the intercostal muscle, there was this thought running in my head. So eventually, I'm going to cut the internal mammary artery, and then the blood is going to spurt out.
Right. Possibility.
That's,
Yeah.
that's a possibility. And then if the blood were to be shot into my eyes, then I have to go through the occupational health. I don't know the hepatitis status of the patient, HIV status of the patient.
Right.
So certainly safeguarding yourself is also quite important. So I had my head turned aside a little bit as I was going through the internal memory artery.
Yeah. And
And
yeah,
then
I mean,
eventually
ideally you have like we
we
should
should
have
have,
glasses, eye protection.
yeah.
Yeah.
So I mean, I think everybody might have appreciated. So uh, we have done this procedure with what called with the bare minimum essentials.
Right. Right. Right.
So we incised, we cut through using the tough cut scissors, and then we met at the xiphy.
Right. So yeah, I think it's you're talking about like fourth or fifth intercostal space. You cut through the skin, softness, and then tough cut scissor until the muscle layers, and you met at the sternum.
We met at the sternum.
Right.
Now, when we reach the sternum, the other thing is we have to use the jiggly saw.
Right.
So the jiggly saw, so the other person holds it. I mean, you hold it from either side, and
Mm.
then you seesaw it to be
Right.
able to cut through the sternum.
Right.
But what happened in this circumstance is I used the same tough cut scissors to cut through the sternum.
That's another trick. No, thank you. So I think tough cut scissors really strong enough. I think they can cut through.
Actually, they can cut. I mean, if your fingers are strong enough, then you can actually cut through the bone.
So you cut the sternum from your
I
end.
cut the sternum with my hand.
Oh wow. Okay.
That was a bit untraditional, but then
Yeah,
nevertheless,
yeah.
it had to be
Probably
done.
say a bit more time because passing the jiggly saw two end and
Yeah,
that's a bit longer, I would
yeah.
say. Mm.
So I've just cut through with the tough cut scissors, and then now that the sternum is cut, now
Right.
we have two chambers now. You're seeing what has been hidden under the chest, and that sight is pretty and ghastly at the same time.
Oh God, this is you see, open a patient's chest.
You open the chest.
That's really really something we normally don't do every day, and definitely it's even new experience for you or all of us.
Yeah.
Again, in terms of open up, is someone holding or you pet the wrist better?
Right. So when we cut through now the two compartments are separate now. Now you have to retract the upper half of the chest
Yes.
so that you'll be actually able to see the lungs and the heart.
Right.
So for that, we there is a metal retractor in the thoracotomy kit.
Hmm.
The retractor um, goes into the superior side and the inferior side.
Right.
And then there is a little screw system.
Yeah.
When you screw it, then it keeps the skin retracted.
So use the retractor to keep
It's
it open.
essentially a retractor. Um, but to be honest, before we could get to the retractor, we used our hands to
Pull it. Yeah.
pull the upper part, the superior part, and then we put the retractor on either side.
Yeah. Yeah. So in terms of cutting through and from the incision and cutting through, how long do you think it took you guys to open this chest?
No, that's a good point. I think it was less than 1.5 minutes.
Less than. That's a very important, guys. Whoever is listening, listen, Lo. So I would say that we're lucky that they already had finger thoracostomy. If not, we did it, and
Yeah.
then less than 2.5. Maybe it could be 2 minutes if it wasn't there thoracostomy done already. So I would say this procedure takes 2 minutes, guys, and it's very quick procedure, and we have to do it in that time frame. And then you put the spreader, and you see what's in front of you. Tell us what did you see?
Right. So the first sight was the beautiful lungs,
Right.
and our my other two colleagues who were at the head end, they passed the endotracheal tube by
Right.
then as well. So it was there in the lungs. So
Yeah.
we had to push the lungs away. We
Mm,
had to push the left lung away to be able to deliver the heart.
right. Okay. So it was intubated, so you can see the lungs. You have to push the lung away, which is absolutely right. And you saw the heart. That means it's within the pericardium, isn't it? Okay.
Yeah.
Right. What
So,
is it? Yeah.
and then we could see as the heart was being lifted off, you
Mm,
could see that the left hemithorax
mm.
was was filled with blood,
I see.
was filled with blood, and it looked like a big container
Wow.
with so
Wow.
much of ketchup in it.
So you need to have suction, need to take the blood out, isn't it? Or what did you do?
So suction, I think, is going to take forever. So we used our hand to scoop the blood out.
Oh, goodness.
So there was so much of blood in
So
there.
much blood that you didn't even have time to suction the blood. You just scoop out.
You just had to
Your
scoop up.
hand.
There was so
You-
much of blood.
You're talking about like more than a liter blood at least.
Certainly,
At
certainly more
least.
than a
Yeah.
liter.
Yeah. Okay, fine.
And at this time, so as I told you, we have already had the rapid infuser. So
Right.
we opened the emergency blood bank, emergency fridge,
Yeah.
and we do have three O positives and one O negative in there.
Right.
So we started transfusing the emergency blood as well.
Right. Okay.
And as the blood was being infused, you could see that the hemothorax is being filled
Build
up
up
again.
again. Okay. This is really, really, I would say, worrisome situation. So, there is a leak somewhere in the heart or somewhere in the chest that even though you have cannulas, big bore cannulas in both arms and infusing within rapid infra, which is say less 1.5 minute, you can put one bag. Uh, and then even though so you clean the chest again, the transfused bars are coming building up in the thorax at the
Yeah,
same time.
yeah.
Okay. This is something I would never, this is something hard to imagine, but I can see that what you're talking. So what did you do next?
So we went through the standard steps afterwards.
Yeah,
So after the heart is delivered, then the first thing to look for is to close. So we wanted to see where it is bleeding from.
yeah,
So the two possibilities are, I mean, which are amenable to repair, are if it is coming from if the aorta is nicked
yeah.
or if the heart is nicked.
Right. So heart and aorta, the two main sources of bleeding you're looking at.
Yeah.
Or did you open the pericardium and look into it?
Yes, we did.
Oh,
So the first thing is one of us has to hold the descending aorta
right.
between their fingers, between the fingers.
They actually hold this thing aorta.
Hold the descending aorta and then hold it,
I mean, hold mean I mean compress and
compressing it. So there are
exactly.
two ways you can do. We can actually put our thumb against the back,
Right.
the posterior surface of the thorax, and then compress it. But I think the best thing I felt was to hold it between my two fingers and my thumb.
Right. So just to
So,
clarify the audience that there because when we open the chest and lots of blood's coming out and we don't know the source yet.
yeah,
So I think that's a very good idea Dr. Uday mentioned to clamp the aorta or hold or compress the descending thoracic aorta. By compressing the descending thoracic aorta, we are stopping blood going below the diaphragm. So those organs can wait, but the brain and heart needs more circulation. I think that's the main reason. So we
indeed.
clamp the aorta or press with between our fingers and stop bloods going down below the diaphragm and make sure they have enough circulation for brain and the heart to keep them alive. That's the main purpose while we're exploring the wound or the source of the bleeding. Someone just mentioned, oh, Dr. Parvez just mentioned then the dissection. Dissection is probably a different scenario in this context. Dissection is within the normally when you say aortic dissection, that's a different scenario. That they wouldn't bleed out; they bleed inside the layers of the wall of the aorta, isn't it? So this is ideally doesn't because bloods are actually in the pneumothorax. I wouldn't say it's a dissection; it's rather open wound somewhere in the heart or major blood vessels which you're going to next step. I would say, what did you do to find out and what happened?
So, as you have rightly explained, that's the rationale behind clamping the descending aorta.
Hmm.
Now, once the descending aorta is clamped, then we have delivered the heart. And then now you have to look if the stab injury has gone into the ventricle.
Right. And
Uh,
another question: when you say a stab injury, the knife wasn't there, was it?
no, so the knife, no, the knife wasn't hanging
Yeah.
on.
Start with on the chest. Was there any stab wound in the chest?
Yes, there were three injuries on the chest. There were
Three
more than three.
stab on the left side of the chest.
They were all on the left side.
All on the left side. Yeah.
There were stab injuries to the chest, to the thigh,
Hmm.
to the abdomen.
Oh, okay. Three
Now there are
different areas.
multiple
Oh,
injuries. So
oh,
as we were going through, then that's where we found.
okay. So what happened? So you deliver the heart. You open the pericardium. You
So
cut.
once you deliver the heart, then you have the heart in your hand. um, then you must incise the pericardium.
Right.
So the rationale for that is if there is any tamponade because of blood loss
Yeah. Yeah.
under the pericardium, then that would be released. So we did make a big incision on the pericardium,
Hmm.
and it felt like incising through a really thick plastic
Very
bag,
tough. Yeah. Yeah. It's very tough and thick plastics filling.
plastic bag.
Yeah. Fibrous tissue actually.
So once we removed it, then we did the incision. Then now the heart is delivered out of the pericardium.
Right.
So now you have the bare heart in your hands, and then once you see the heart, then you inspect everywhere to look for any incisions.
Was the heart beating? That was my next question. Is it beating heart or
No,
not?
it wasn't.
It wasn't.
It wasn't.
Okay.
It wasn't. So that's when I started the internal cardiac massage.
Okay. Okay.
So now the heart is in my hands, and then you do resuscitation
Right.
with your hands.
Yeah, exactly. I think it's a very good skill. So as I say, when you open deliver the heart and heart is not beating, and also you can't see any obvious point of bleeding or open wound.
No. So we
Yeah.
did then you do a 360 view
Right.
inspection of the
Right.
heart to try and see if it is bleeding. And it is very similar to, let's say, to find a punctured balloon.
Yeah. Yeah.
If there is a hole in a balloon, then if you immerse it in water, then you'll see the bubbles coming out, isn't it?
Yeah.
So
Yeah.
likewise, we had the rapid infuser infusing blood. So
Right.
if there were any incision that we could not see with our eye,
Hmm.
then you should be able to see the blood gushing out through those holes.
Yeah. Yeah.
So that is not something that we could find. So, however, we were prepared if we find any incision into the heart, then to be able to suture it. So we had our silk sutures
Ready.
um, with it.
Okay. So this is interesting. So it's a huge amount of blood filling the hemothorax and transfuser going on. You deliver the heart, examine 360 and everywhere. You can't see any gushing blood and no open wound. So heart was, I mean, surprisingly, it was intact.
Yeah,
Oh,
presently the heart was intact,
all right.
and we were continuing with the resuscitation, with the internal cardiac massage,
Yeah.
and the blood transfusion was going on.
Yeah.
And it's a very bizarre experience that I've had. And as this process was going on, and then we were trying to find where the blood was coming out from,
Mm.
and it was so dark inside.
Oh, absolutely. I mean,
It was so dark inside. I mean, you have the sternum, then you have the vertebral column,
yeah.
and then you have the hilum, and then it forms like a little cave. That's the best way I could describe both the hemothoraces. So the left hemithorax was like a cave,
Hmm.
and then we didn't have any operating theater lighting.
That is something I would really worry because if you don't have actual lighting or even headlamps, sometimes they say use
Yeah.
headlamp because it's actually a dark space in the
Yeah.
inside the thorax and it's a narrow space, dark. And if you don't, like a lot of people are walking around, if you don't have a light, good light source, so how did you manage that situation?
So I think that was one of the downsides that we had. So we had to use our pen torches,
Which is not strong
which is
enough.
not good enough. And then eventually I asked we have a portable light, which we use for suturing, minor injury procedures.
Right.
So I asked my nurse in charge to get to get that lamp. So eventually, after a minute or so,
Mm.
we could get a light source, which is better than a torch light, but they're not as good as an operating uh,
Right.
theater light. So it was very dark inside, and it was very difficult to see where exactly is this person bleeding from.
Mm. But sometimes some of the resuscitation where you have the head of the top of the head
Yes.
there.
Yeah.
For some lights, or there wasn't light there.
So we didn't have that.
I see. I
The,
agree with you. Some of the situation you can't because it that's not normally used. That's what I'm
indeed.
saying. Yeah.
Yeah. So that was one downside. And however, we were able to see the arch of the aorta, and but then there were no sights of bleeding from there.
Hmm. Right. At that moment, I mean, in terms of ED, any trauma surgeon, vascular surgeon, or anyone in that available at the time?
Oh, actually no. Because I think the only surgeon that could help there would be a cardiothoracic surgeon.
But
Um,
that's not the case, though.
but we didn't have a cardiothoracic surgeon. We had a general surgeon,
Yeah.
and an orthopedic surgeon.
But they're not normally trained for that procedure.
No.
No. Hmm.
But even for them, they would see what we are seeing.
Exactly. Even I heard a couple of situations where even cardiothoracic surgeons don't do this procedure routinely, you know.
No.
So this is probably even new for like many cardiac thoracic surgeons in this clamshell thoracotomy. So you're right. So let's see, was there any injury in the back? Dr. Parvis was asking.
That's a good thinking. That's really lateral thinking. That
Mm.
is, I
Because where
really,
is this bleeding coming from? Or yeah,
yeah, that's very good thinking. And to be honest, I've done a head to toe search after that.
right.
There was no injury to the
On
to
your back. So talk us through what's happened because obviously if you can't see the source, you can't stop the bleeding.
no.
So how long did the search go and what happened at the end?
So we searched, and then um, after clamping whatever we could clamp, uh, and the blood transfusion was still ongoing,
So as
we
in,
could still see the hemothorax filling up.
did you clamp the lung twist or clamp the hilum, the lung
Yeah, we
component?
did the lung twist.
It's the lung twist.
So we
Okay.
did the lung twist, especially on the left-hand side. We did the lung twist,
Right.
but the hemothorax was still filling up.
Thing up. Right.
So that's something that didn't help.
Hmm.
So I
How
think yeah, eventually, um, so we resuscitated for another 10 minutes. We did the internal cardiac massage,
yeah.
and then we tried to address everything that we could address. Um, but then eventually you have to make a decision.
So how long did it pass, like from the onset until making a decision when you thinking that you should stop looking?
I think overall it was 25 minutes.
25 minutes. I think it's long enough.
Yeah.
That's what I'm thinking. I think it's long enough. I mean, is someone profusely bleeding even after transfusion, open heart, internal cardiac massage, and cross clumping, the not cross clumping, like compressing the descending thoracic aorta, and there's no source, which is not unrealistic. It can happen even with experts. I would say it's not a easy thing, and it's a 20 minutes already, no signs of life. So
Yeah.
that's the time we start to think whether we continue or stop.
Yeah.
Okay. So was it like a team decision? How did you make the decision?
So at 25 minutes, then uh, so I mean essentially I made the decision to stop it,
I see.
and then I've announced it to the team,
Hmm.
and just asked if they had any objections.
Right.
Uh, but then everybody has seen that we did everything that we could do,
Yes, absolutely. Absolutely.
and nobody raised any objection to that decision.
Hmm.
But however, everybody, I mean, quite a few of them were traumatized, I would say.
Of course, of course. This is another part that as a ED team leader or as a easy AD registrar or consultant, I think most of the audience, including ourselves, could be traumatized in that scenario. and it is traumatic. Obviously, it's a very extreme and rare procedure for anyone in the medical field to observe or even perform. So, what did you do at the end? A debrief or anything?
Yeah, so once we called it off, then we've done a hot debrief.
Right.
We've done a hot debrief. Oftentimes, addressing what people might have gone through, um, just acknowledging them and then trying to verbalize and find the right words for them is quite comforting
Yeah,
for someone who has experienced that trauma.
Mm,
So we did a hot debrief, and especially the paramedic who was doing the chest compressions.
yeah, yeah.
They were quite shattered as well.
Yeah, yeah, absolutely, absolutely. So as I think it's a very important. These are the scenarios when you need a hot debrief just to vent people's emotions or any questions. What did went well? What was what did you learn from it?
Yeah,
And also it's a shared learning and shared and effort. And this is the best you could have done.
yeah.
Anyone could have done. Okay. And the patient's family, anyone later on?
So we had a lot of police come in. We
Right.
had a lot of police who have come in who helped to make a wall
I
between
see. I see.
between the other side and ourselves. But I didn't have any contact with the family
No,
after.
okay. The police came as a like a security. Oh,
Yes, indeed.
I see. And
And
also, it is a crime, so police needs to investigate the crime.
yeah,
It is a crime scenario. Okay, fine. Wow. So, Dr. Wuda, it's this is a extreme situation. I can't even imagine I mean, how difficult or how challenging it was from your end coming to a shift and handling this situation in the night time at
yeah,
10:40 or something. This is the time when nobody's around in the hospital, like all the
yeah,
consultants, everyone is gone home, including the ED consultant. And as a registrar, I would say, you done I would say extremely well, even like from my perspective, it's an extremely well managed situation. There would be no difference even there's the ED consultant, even cardiac thoracic surgeon was there. That is my understanding what you said. Okay. And you manage everything within the time, and you had to make the decision at the end. And it was a difficult one, but I would say that's the best in terms of best interest, that is. From the audience, I need just to open up quickly. So for the audience, Dr. Parvez just mentioned that he had something similar. Dr. Parvez, are you listening?
Yes, Assalamu alaikum, Dr. Farooq. How are you doing?
Hi, Dr.
Sorry
Parvez.
to
No,
sorry
that's
to
fine.
arrive late. I missed
No, that's
the
fine.
initial introductions and everything. Very, I would say it's a very encouraging and very gutsy action taken by the honorable doctor here who is presenting the case, and it needs nerves. As I worked in the ED and the surgery department, I had a previous history of working in the surgery where I had to open up the abdominal cavity and even sometimes the thoracic wall as well in order to do some surgeries. So I understand what adrenaline rush it was for the whole team, as well as with the short of equipment and time, space, and lack of the working hours, owing to the working hours, late working hours, so where you don't have the consultants to overlook your other team members to give you a helping hand. So I could imagine what he went through at that moment, and whatever it was done for the best interest of the patient. And sometimes we are not that much successful. And we had a similar case. I was just, my hands were itching to just bring this topic out. I had a similar case. We had a guy with a multiple injury to head and face and arms and limbs, and he was hit by a stick containing multiple nails, and he was hit on the back and on the chest, and then he ended up with bilateral pneumothorax. He traveled all the way from a city which is like 6 hours from Dhaka, and he was still alive. And he was when he arrived in the emergency. We didn't have any pre-alert. We didn't know about if the patient is coming in. We were all taken for a surprise, And once he arrived, he was obviously he was. We were lucky. He was surprisingly he received some initial management in nearby clinic there, and then he drove by ambulance 6 hours and arrived in our emergency at around 1 2 a.m. in the morning. And by the time from the time we received him, he was gasping for air. I could see he was in quite a distress, respiratory distress. All his veins were engorged, and I couldn't hear any breath sound bilaterally. And so, but his pulse and blood pressure was maintaining. So I took the gutsy move of taking him to CT CAT scan, where he saw the bilateral pneumothorax. His all his internal organs was just squeezed against his vertebral column. So immediately I called on to our thoracic surgeon. He was just 15 minutes away. So within 15 minutes he was here, and we put a chest drain, and definitely he was in surgical ICU for a few days, and then onwards to the cabin. And definitely he made it through. He made it out of the hospital. Yeah, I talked to him, and the last time I talked to him, he had this sutures taken out from the skin, and there was a light at the end of the tunnel, deep tunnel. Yeah,
I
that's
think
my story.
Dr. Tavis, that's an example of a severe assault and blunt trauma, I thinking, in multiple areas in the chest, and this ended up, you say, as you mentioned, the bilateral, probably pneumothorax or
Yes.
punctured pneumothorax, and which has decompressed. And I'm glad that that didn't end up in thoracotomy or something, open.
Yes, yes. The common problem with the bilateral pneumothorax is patient suddenly has a cardiac arrest, and then we wouldn't be able to bring him out.
Yeah.
That's the problem.
Exactly. Well, yeah. So those are the scenarios. I think it depends on the country or hospital you're practicing. Dr. Prabh's work, just for everyone knows, is in United Hospital. I used to work there. He used to my colleague, so I know Dr. Prabh's what he's talking is difficult for many steps to be taken by the ED physicians there. But ideally, in if I say in UK an ideal practice, if we
Needle
see
decompression.
if
Yeah.
we clinically suspect tension, we decompress in ED before the scan. Okay, we
Yes.
put the needle or chest drain even
Yes.
before the scan, and then that might save the life. But in this case, he was lucky enough to have the scan and then done later on by the thoracic surgeons. But that should be ideal a ED procedure, I would suggest.
Yes.
Yeah,
Yes. Of
I'm
course.
saying it's not ideal everywhere, but it is ideal. And yes, if the tension pneumothorax is relieved and he is, he said he's maintaining pulse and blood pressure, and we wouldn't open the chest at the point. Of course, in the blunt trauma, the guidelines are a bit of gray, I would say. It is even someone went into, so we are talking about scenarios when there is a traumatic cardiac arrest. So loss of signs of life within 5 to 10. So I think in blunt trauma, time is very short. I mean, within 5 minutes or something. In terms of traumatic penetrating chest wound with traumatic cardiac arrest within 10 to 15 minutes. So that's what Dr. Uday was talking. And also in blunt trauma, I would say time is that guy probably very lucky not to go into no signs of life. But thank you, Dr. Parvis. Thanks for sharing. Again,
Thank you so much.
I would say in terms of trauma, this is probably the extreme procedure any trauma surgeon or any pediatrician will ever do in their life. This resuscitative thoracotomy in emergency department. Even sometimes in UK they do in the pre-hospital, isn't it, Dr. Uday? In
Yeah.
pre-hospital team staffed by doctors and critical care physicians that they can do in the field because sometimes they don't even have time to bring that patient to ED. Yeah. So those are the things I think is a very well learnable skills that we need to at least have it in our mindset that in case worst case scenario, do we have to open it? How do it? So do some. I would what I say. I went to the thoracotomy course last week. It was really amazing. We went to the cadavers. We practiced. Now, if I see in real life, I probably already ready in my head. So I would say if someone can do a human cadaver, do some animals or something that you can do in your comfort zone. So something that actually needs to be physically practiced, which is ideally, I mean, if you can, if not, just be ready. I mean, as I said, the procedure is less than 2 minutes, and it that might save this life. Okay, there's an open source of bleeding, and Dr. Woody could see it. I'm sure he would be able to stop it, at least hold this, or stop it with some suturing or staple, whatever it is. Okay, or even compression by hand. So if we can see after opening the chest, if you can see the source of bleeding and you can stop it, you might probably save some life. And these are success rate is not really great, to be honest with you. These are really rare situations. I would say people actually make it to the normal life, which I've probably there are very few scenarios. I know there is one in Louisiana last 6 months ago. I saw the video on YouTube that says the guy who's actually a blunt trauma ended up having open thoracotomy and survived, and actually he walked out in after a month or so. But these are real scenario. So anyway, I think we are nearly there. Okay, guys. Any last questions? Any comments? Shout out. All right. If not, I will have to summarize. And obviously, a massive thanks to Dr. Uday. Is there any last?
Thank you so much for giving me this opportunity
No,
to
no.
speak. Thank you.
Dr. Uday, I mean, absolutely. I mean, you are the only person that I know who done it. Yeah, I would say in my circle, the only person who actually done it in real life. There are other people's, but I'm not that close to them. But anyway, Dr. Parvez is here. Okay, and is there anyone? Mohammed Ibrahim. Okay, all right. So we are nearly finishing again. Thanks everyone, and this video is recorded, and I will probably upload in our group to whether if you missed anything. If you have any questions down the line, and you want any further discussion session, we didn't do a practical session. It's not virtually, it's not feasible, but maybe in the future we may try some hands-on things virtually. Um, any feedbacks, any comments that you didn't remember now, or you might come back to me later, you have my email. And any question to Dr. Uda, you can just come through me and just let me know. I will pass it on. And massive thanks, Dr. Uda, again for today. Any last words for the audience? Any comments?
Abdullah. So certainly, I mean, thanks, Abdullah. You're doing a phenomenal job in inspiring your colleagues from back home. I think you should keep doing the good work. Um,
Thank you. Thanks. That's what I'm saying. This is the good one. I mean, you guys are coming in, of course. I'm sure. I mean, I'm borrowing your knowledge and skills for other people, but that's definitely
so I think our community is quite a tight-knit, close community, and certainly whatever we learn, we must.
yeah.
So as what they say is the actual meaning of a doctor is teacher. So
True.
so that fulfills our role.
Exactly. The more we share, actually, the more we learn. That's how I learn medicine, and the same thing applies. All right. So finally, again, it was an excellent, I would say, is a very intense experience for all of the audience. And people are there are a couple of people are thanking Dr. Uday already. I'll send you guys a feedback form through emails, so you can have your comfort zone, give some comments, some suggestion or any questions to improve. I would be really glad. And on that note, it's already 11:01. I will conclude our discussion today. Thank you, Dr. Uday, and thanks everyone for joining in. We'll
Thank you.
keep in touch and we'll do further sessions. Thank you, Dr. Uday.
Thank you, Doctor.
Bye.
Bye.